welcome to Current Affairs. My name is Nathan Robinson. I am the editor-in-chief of Current Affairs magazine, and I am joined today by an extremely special guest. It is my colleague, Current Affairs managing editor, Lily Sanchez. Hello, Lily. No, but the reason Lily is on the program today is because Lily Sanchez has a new article in Current Affairs magazine on our website called "We Can't Make Healthcare Fair Until We Reject the Logic of Scarcity." And we are going to discuss that and some of Lily's other writings and observations on the American healthcare system today. Now, what our listeners may not know about you if they've only heard your voice in our previous podcasts about Hillary Clinton's masterclass or the Minions. Before joining the staff of Current Affairs, you, Lily Sanchez, were a pediatrician, and you left medicine for the vastly more lucrative field of left publishing. As a joke, left publishing is, as we know, not lucrative at all, except spiritually. And I wanted to start there, actually, with you leaving medicine to come and join us. We know what some of the pull factors may be about why it's enjoyable to write and edit. But I want to talk today about the push factors that might have caused someone who presumably entered medicine with an idealistic desire to help, children who are sick to not be sick anymore. Why someone who had put so much time and effort into attaining, qualifications and skills would leave that behind. And I take it has a little something to do with the structure of medicine in the contemporary United States.
Right, that's true. I think one of the major factors, though, was something that I knew early on in medical training, which was that there was going to be some degree of a challenge for me to work in a clinical environment because I'm introverted. And so, like introverts know, we require a lot of downtime, a lot of alone time. And that doesn't really happen a whole lot if you're in a clinic or a hospital seeing patients all day. And so I knew that was going to be an issue. I knew it was going to be difficult. A thing about medicine, about seeing patients that's like performative. And I don't mean it in a negative way. I just mean it that there's a role you have to play, right? You have to comport yourself a certain way. You have to sound like everything's fine, everything's under control. You want to be sympathetic, but not too sympathetic. You want to be authoritative, but not paternalistic. There's all these things that have to go on in your performance when you're seeing a patient. And you don't get a lot of time to see each patient. So you have to learn how to establish this kind of rapport very quickly. And you have to learn how to do it repeatedly over and over and over and over again. And it does get exhausting, I think, for anybody, but especially for an introvert, it gets really draining. So I knew going into it, that was going to be an issue.
Sure.
So I can't say that's medicine's fault. That's just my personality.
Well, you can kind of say it's medicine's fault because, as you said, it gets worse when you can't stop doing it because you're having to see person after person after person.
This is true. No, you're right. There is a medicine factor in there. And the profit motive does have a lot to do with that, right? Because the profit motive is going to dictate your day, basically, because it's going to dictate how many patients you have to see in some sense. And so that's the other part of it, right? Which is like the profit motive, which is just the sense that there are so many frustrations in practicing medicine that just don't have to be there. It doesn't have to be that way. And yet it is that way. And you can't change it. So at some point, everybody's going to deal with like the cognitive dissonance of that, of dealing with like insurance companies or artificial scarcities in the system and not being able to take care of your patients the way you want to because your insurance company doesn't want to approve that treatment or that medicine or something. So you can't change those things. At best, you can like make peace with them, but it does, I think, it just weighs on you after a certain amount of time. And I had gotten to the point where I kind of felt like I needed to take a break. I didn't exactly have a plan for what I was going to do, to be completely honest. I didn't. I thought I might maybe travel a little bit But then a few days after I quit, I actually got a notice from the Bernie campaign saying, hey, do you want to volunteer to be a canvasser? So then I got caught up in the Bernie campaign. And then that took me to the pandemic. And, and then a year later, I applied for this job. So that's kind of how I got here. But it was a number of factors. I can't entirely blame it on the insurance companies, but at the same time, I can't.
But even the first thing you mentioned, which is that it's not a profession suited to introverts, you can imagine structuring it in a way such that it was more possible or less possible for people who find it difficult to be on for 10 hours straight and being on for a reasonable amount of time. I want to dwell on what you mentioned there, which was artificial scarcity, because that is kind of at the heart of the article that you have just written. Scarcity's in the headline. Scarcity, that term runs through the piece. When you say the frustrations of artificial scarcity, what do you mean by that?
Well, the way that healthcare works is that you as the patient, in order to be seen in kind of like a mainstream medical facility, need to have some kind of payment method because the cost is prohibitively expensive for most people, with the exception of the independently wealthy. So you need a payment method. For many people, that comes through the health insurance they get through their job. For many people, it comes from, Medicare or Medicaid, a public program. And then for still many people, there is no payment method. There's no insurance. And so everybody's left to kind of cover themselves with a payment method. And as a result, the people in charge of that payment method, they get to decide what is, what care you were entitled to, right? Because these companies, these health insurance companies exist to profit. And so how do they profit? Like, they profit in a lot of ways, actually. It's not just denying care, but one of the main ways is to just deny care or to put obstacles or boundaries in the way of the doctors taking care of you, or to put obstacles in your way in terms of, getting access to the care that you need. It's a doctor's appointment, a procedure, a medication, something like that. There are obstacles put in. So you're dealing with that every day. And so, like, an example for me as the doctor is, I see a patient, I want to prescribe a medication to them. I get some little notice in the computer, not covered by the patient's insurance plan. So I'm left with, okay, is the electronic system just outdated? Because, these drug formularies are changing like all the time, right? So I'm like, is the computer outdated? Can I have a staff member call and find out what is covered? Am I really okay with not using the preferred thing? Like, there's all these like decision points then that open up before you that you have to negotiate in the middle of a busy day. So it's the insurance company mandates. It's not just do they not cover like a medication, but it's, for example, prior authorization. Like we talked about this a little bit with Mark Vonnegut, the pediatrician that we had on the podcast. And prior authorization is basically just an obstacle to care for patients. It's, it's sometimes a form, it's a phone call, it's some kind of communication from the insurance company. Hey, we need more information because we're challenging you on whether your patient needs this medicine or this service or this consult with a specialist or something. So you got to go in, you got to fill out these forms. Sometimes they're kind of ridiculous and you're like, I don't actually understand it. Like, it's trying to trick you, like this or this, but not this or this, but this or this. And you're like, oh my God, my patient just needs their damn medicine, So that's like the problem with the third party for-profit payer, is that they are trying to dictate things. And you, on the one hand, on the doctor, are trying to help your patient, and there's a conflict there. And inevitably, it's going to be resolved usually in the insurance company's favor, unless you can fight them, which is a whole other story of how you have staff and people in your clinic that have to do that, have to fight with the insurance companies, basically.
Yeah. And so you're having to deliver worse care, essentially, than could be delivered. That there is no obstacle in the universe of conceivable possible medical systems. There is no real obstacle, but in the one that we have made, there is an obstacle. And the frustration that you're talking about comes out of the fact that that you could give them better care were it not for this artificial. And the questions that you as the doctor are having to think about in your day-to-day treatment of the patient are stupid questions, because they are not questions that are related to, what does the sort of thing that should get to occupy your mind as a doctor, which is, what is wrong with this person? What does this person need? And how can I give them what they need?
Right. And so it's a scarcity of things that are available that the patient needs that the payer does not want to happen or wants to at least fight you on or delay it on. Right. So that's the kind of scarcity. And then, the scarcity that we're talking about in the piece that I wrote is the scarcity within the safety net system. Right. So the piece that I wrote was a book review by a hospitalist who's a physician writer, Ricardo Nuila, and he wrote a book about the safety net hospital that he's worked at for over a decade and kind of what he's learned from that system and how he thinks we could apply that to healthcare or to healthcare reform. And what he describes in the book is essentially a system of scarcity. It's a system that does try to be fair to patients. They do try to determine, who's the neediest and how can we help people the most, but with a limited amount of funds. Now, they get their funds mostly from public sources, so property taxes, Medicare, Medicaid, and then a little bit of insurance, like a little bit of private insurance, and then whatever self-pay patients have to pay. But there's a scarcity there, right? And as I mentioned in the article, if you're going to try to raise the budget of this healthcare system, you're going to have to go to the lawmakers and say, we need more funds. Therefore, maybe we need to raise the property tax rate. So then you're at the mercy of, these lawmakers who they don't want to raise the property tax rates on their constituents. So then you're left with this problem of scarcity that depends really on kind of the whims of these legislators or these property owners. And I think in one of the articles that I linked, it mentioned, what was the cost to Houston for a $50 savings in property taxes? I mean, it was something ridiculous. It was like, your tax bill's not going to go up by $50. But as a result, this healthcare system is not going to get the money that it needs.
Well, I think what's interesting about this is that, you identified the profit motive as a real problem in healthcare. And obviously that's true. There are lots of ways in which, if your care is being delivered by a company has a built-in very bad incentive to deny you what is good for you because denying it is good for them. But this hospital that you had worked at and that the doctor who wrote the book that you reviewed worked at is a publicly funded hospital. So one would think that this takes away some of these bad incentives and gets us closer to the kind of hospital that we want to exist, something that, where people can think, well, what actually serves the needs of this community rather than what serves the needs of our shareholders. But as you point out in your piece, common to both for-profit medicine and a public hospital like this is this scarcity mindset that says we don't have enough to give everyone what you as a doctor think would constitute the care they deserve.
Right. And I think the interesting point there is that you can't really separate the two, like the for-profit system and the public safety net system, because one kind of grew out of the other. I mean, as health insurance through an employer became the dominant way that people got insurance, but yet wasn't enough to cover everybody, you see these like growing gaps, in the insured rate. In other words, like just increasing numbers of uninsured people. And it doesn't look good, right? It's a huge problem. And so I think this is 1965, right, when this public hospital district is created through a ballot referendum. And so the citizens of the county voted on it. And the system, though, that was created, like it grew out of that scarcity, right? Because their whole mandate is to take care of people that the other part of the system left out, right? So like the indigent and the poor. And I think even in the book, he says that in the US, it's the county that's responsible for care of the indigent. Like that's the way we do care in the US. And it's kind of like this decentralized thing, which I think is similar to public health. We talked about a tiny bit in the piece I wrote a couple of years ago about the pandemic, but public health is kind of a state thing in the US. And I think similarly, the care of the indigent is like a county thing. That's why that system grew out of this, because some leaders were saying, hey, what are we going to do about this? We've got a lot of people that just are not getting care, or they're getting bad care, and we got to do something about it because it looks bad, right? Mm-hmm. So that system, I think, essentially grew out of the for-profit system, leaving so many people out. So that's why I think you can't really separate them. And I think to critique one means you have to look at the whole thing and see how it fits within like the overall scarcity thing, which says like, we just don't have enough to cover it for everybody, unless you happen to work a standard job.
And the difference between looking at the whole thing and not looking at the whole thing is part of, as I understand it, the critique that you make of the book, which is that essentially, I think he calls this book a love letter to this hospital. He really thinks that this hospital, the people at it, do a very good job of treating the population that they treat with the resources they have. And he's very proud of the work that they do and considers this almost a model of fairness, this public hospital. But one of the criticisms that you raise here is, well, he's just looking at how this hospital gives out what it has on the assumption that that's kind of the question of justice, is how does this institution allocate the resources that it has been given? But what we have to do is look more broadly at, well, why does this hospital have the resources it has in the first place?
Right. And that's always the feeling that I got working in that system. And in our second year of medical school, we start clinical training in hospitals and clinics. And I think that's the feeling I had from the beginning. I was like, you understand when you enter, this public safety net system, that there's another hospital just like a block or two away where everything's fancy and nicer. And it just like has a completely different feel. You understand that there are these separate tiers of care for people. And you're just like, I don't know, like this doesn't quite seem right. And so for me, like it never really quite felt right. I think you can say that while also being respectful of people who do work in the system, right? Because like I worked in a safety net system myself, although it wasn't the same system. And so I think you can say, yes, we are doing the best we can. We are trying to be fair with our patients. We are trying to give quality care. We're trying to treat people like human beings, essentially, in a society that often doesn't. And so, like I said, there's honor in that. There's meaning in that. That's good. But then I want to kind of separate out the fact that we can't just look at that system. We have to say, well, why is it that some people end up in this system and some people don't? And like the way I see it, when I look at the patients that he talks about in his book, he kind of tells their story and what led them up to their encounter at Harris Health. And I see that like many of them have been on the receiving end of a lot of injustice in their lives. And so to me, that kind of compounds. And so when you end up in this system, you've already experienced like X number of injustices, whether it's related to healthcare or immigration or other issues. And you end up there and yes, we want to do the best we can for you, but that just, to me, like that's just not enough. And we got to look at like the social determinants of health. Now, I'm not saying he doesn't talk about those. He does mention that there are social determinants of health that oftentimes the medical profession like ignores or just doesn't factor in. And so he mentions that a little bit, but then that discussion kind of veers off into like a related issue about protocols and how we deal with things. So he doesn't really like make the argument that if we look at the social determinants of health, which are huge, then we have to, if we're talking about fairness, then we got to talk about those too.
Well, right. So the problem is that he takes those things kind of as a given, as I understand it. Like, by the time I, the doctor, see the person, these things have happened. So now there's a debate over, given that these things have happened, what do I owe these people? And this hospital, this public hospital, he thinks is doing a good job of answering the question of what you owe these people, again, based on the scarce resources that you have. You point out that he talks about all these calculations that the hospital does to try and make sure that they are optimizing the fairness of their distribution of health, which involves a lot of means testing, from what I understand. A lot of like, well, the people who have the least, they have to pay the least, and the people who have the most, they have to pay a ton more. And that's fair. Means testing is fair because you are using a model of justice that says, essentially to each according to their need, which is, a classic socialist phrase. So that's justice. So maybe you can tell me what you think the critique of the means testing is justice approach is?
Well, I think if you just look at the outcome itself, like what outcome does it produce? And then we can make a judgment on whether we think that that's right or not. So, for example, one of the patients that he chronicles is this man, Stephen, who ends up at the hospital because he's got cancer and he lost his insurance because he lost his job during the pandemic. So he couldn't be seen somewhere else. He was sent to, the public system where they'll see you regardless of ability to pay. So he's got to submit to the means testing. He fills out the forms. It turns out he's a homeowner. So that's an asset. And so at the end of all of this process, we find out that for him, the system is going to see him and take care of him, but he's got to pay $32,000 cash. And I mean, I just don't think that seems sustainable, especially for a person who doesn't have a job. I mean, clearly he's going to have to go on some kind of payment plan for this, right? And that's just one hospitalization. What about the other healthcare he needs for the rest of his life? What about complications of the cancer treatment? What about, all these other things? I don't see that outcome as being very sustainable. In another situation, like this patient named Roxana had just suffered a terrible medical complication where after a surgery for cancer, she essentially lost all of her limbs. Not all of the limbs, but most of the functional parts of the limb, the dead parts she had to have taken off. So then he's talking about, well, based on her situation, obviously she's unable to work. She's undocumented. And so for her, they do this calculation and they say, okay, you have to pay a $3 copay. But then I consider that outcome and I'm like, why not just zero? I mean, 3 is so close to zero. Why not just zero considering everything this patient has been through? Again, I get it, like this idea of, well, they're taking some responsibility for the health. They're going to pay the $3. It's fine. And I'm just like, it seems petty. I don't know. That didn't sit right with me. And so when I look at the outcomes of the means tests, I'm just not that impressed with the outcomes when we have other things that we could do, like Medicare for All, that would mean that people wouldn't have to pay anything. And they also wouldn't end up in those situations where they were kind of tossed into a system for care when nobody else would see them. I don't feel like the means test outcome gives very good outcomes. And it also can even kill you, right? So another patient that I just want to mention briefly that he talks about and that I bring up in the piece is a young man, Geronimo, who needs a liver transplant. And it's complicated because he's getting SSI. He had Medicaid, but then he lost it. It turns out that $179 in SSI income was preventing him from getting the Medicaid, which would cover his transplant. So to even be considered for an organ transplant, you have to be very sick, like for a liver transplant. And so the man's critically ill. The hospital team is desperately trying to find a way to just get him that Medicaid coverage so they can transfer him to a transplant hospital. They go to heroics. And I mean, it's good. Like they're fighting for their patient. That's what they should be doing. And in the end, he gets approved, but it's too late because by the time he ends up at the transplant hospital, he has a very bad bleed in his brain. And so that's it. It's over for him. The family pulls him off life support and he dies. And so you think to yourself, wait a minute, because of a means test, yes, this was a means test that was the state of Texas, so not Harris Health, but this was a means test that basically resulted in this person being dead when they didn't have to be.
All the time you spend checking a person's bank statement to make sure you're being optimally fair is time that you are hurting the person. And
I put at one point in the piece, I do think that to look at it just in the system of fairness and means testing, it's almost like a justification for why this is the way it is. Because you're like, well, I did everything within the parameter. I did everything to the book, did the best I could. And while that's true, it's also true that we just don't have to be doing things that way.
Right. That seems to be at the heart of your critique in the book review of his notion of fairness, because in many ways, you and he share a lot of similarities. You worked at the same hospital. You both have a lot of the same concerns with the same population of people. You may have seen some of the same patients at various points. So I was kind of surprised when I first saw this book came out, and I was like, "Oh, it's the hospital you worked at." I thought, "Oh, Lily will love this book." But then you're like, "No. There's a real serious defect with the notion of fairness that he talks about and the notion of fairness that you actually cite a lot of US politicians. You have quotes from Joe Biden and other people talking about how they believe in fairness and these various things are unfair. And he said, well, it really matters how we conceive of what is fair. And if we say, well, it's fair to do the means test and then to charge the one guy $32,000 because he has some money in his bank account, to charge the other person $3, we are legitimizing an inherently unfair and deeply structurally unfair situation and not asking questions like, well, is it fair for anyone to pay $32,000 for something that should be a basic entitlement?
Right. And so, in thinking about like this idea of like fairness, I don't really call it this in the piece, but I think it is essentially it's a kind of liberalism, right? It's a kind of, these are the constraints we have. This is the best we can do. And so, we're just going to do the best we can. And it's fair and that's good. But it's not looking at the bigger structural picture. One of the main reasons, I wanted to respond to this book with an article is that I think his kind of doubt around Medicare for All, I think really needs to be challenged, because he acknowledges, hey, some people think we should just do away with the tiers that we have now and we should just cover everybody. And he's like, well, I'm not sure everybody's going to accept that. In preparing for this podcast, I was reading one of the pieces that you wrote where you wrote last year about Luke Savage's book, The Dead Center, right, which is about liberalism. And there's a quote in there where he talks about how, at its core, what liberalism does is it says that, you can't change things too much or too fast. And that for whatever reason, there are going to be obstacles. People aren't going to accept it or whatever. We can't do it. And I just thought to myself today, to me, those sound so similar. Well, people aren't going to accept it. I don't think they're going to like it. And I just feel like that's incorrect. I think it's incorrect. I think even as I put in the article, I think one of his very patients, Stephen, the guy that we're told is very conservative, I think he's even a good case study in how you can convince people that systems can work for them. If you treat them well and you give them good care and the facilities clean and, all these things that we're told Stephen, his conservative patient, liked about the system, even though he's very skeptical about the government doing that, So I just feel like we're kind of being told in the book, yes, there are these horrible injustices, but we're going to do right by them and we're going to continue the fight. Whereas I want to be I don't really want you to be having that fight with a means tested thing where you don't have enough money for them. You don't have enough resources for your patients. I think we can actually give everybody all the resources that we want. It's just that, the for-profit companies are hogging the profits that are keeping us from the resources we could be having.
Yeah, and you point out that raises some objections to Medicare for All they're basically dishonest, saying, well, the people won't get private rooms anymore, and I think people ought to get private rooms. And it's well, you can give people, first off, no Medicare for All system that is being proposed does not prevent people from buying additional. I believe in full communist healthcare, but the systems that are being proposed, in the United Kingdom, there are private hospitals and there's private health insurance. No one who can afford a private room is denied one in countries that have a basic socialized healthcare system. So it's a dishonest objection because the people who can pay for it now get it, the people who get it under the system. So when you start to raise dishonest objections, you start to wonder, well, why? Why do you actually oppose this system? And I don't know what you think. There is something in, as you said, liberalism that first off seems to just fear changes that are too radical and come up with whatever objections it can throw at them, even when those objections are really, really dishonest, like all of the stuff that was thrown at Bernie on Medicare for All in the Democratic debate stage about, people will lose their health insurance. It's no, they don't tell them that. That's implying they're going to be uninsured. They're going to have better insurance than they had before. Why are you raising this dishonest objection? And the other thing I think that I start to realize when you get all these dishonest objections is, do you really share the view on what the injustices are? And something I take from your review is I don't think you and Nuila look at that hospital and see the same level of injustice. I think he sees the injustice as being, you think the $3 copay is unfair. You think the $32,000 fee is unfair, and you're angry about it. And I I mean, I didn't read the book. I only read your review of the book and some of the other reviews of the book. But I don't get the sense that he shares the kind of anger at the same things that you have.
Right. I mean, I think I agree with that because, like I said, when I first started working in this hospital system, I may not have been able to articulate why, but I just felt like this is not supposed to be. Like, this is not the way that we're supposed to do things. We're not supposed to section off certain people, you know, particularly racial, ethnic minorities, immigrants. We're not supposed to just put these people in a bucket and then, you know, get people who are really nice to tend to them. I didn't feel like it was right. And so my question is like, why does this system exist rather than let's optimize what we can because this is fundamentally the way things are. Like, I just don't accept that. I don't think we should have these tiers. And yeah, I am really angry about the 32,000 and the 3. I'm just really angry about it. Like, when I read the book, I got really angry.
Yeah, you got angry at parts that he's not trying to get you to be angry at. It does remind me that, you know, kind of going back to where we started the conversation, you know, we talk a lot about the financing of healthcare in the United States. You know, how much is fair for people to pay? Answer usually 0. And if you're someone like yourself or myself, a socialist who believes that all medicine should be free at the point of use. But the qualitative dimension of care, I feel like, is kind of left out of these discussions, because in the Medicare for All, it's all about how much you're going to pay, not what your experience is going to be. You've also you wrote that great article on zombie healthcare, zombie medicine, which also drew from your personal experiences. And, you know, you were talking at the start about, you know, people just being seen too quickly, not being given the time they should be given. So perhaps you could also tell us a little bit more about the unfairness that you think we need to see in what people get and not just how much they pay for it.
So to go to that zombie care piece, that was a phrase that Dr. Mark Vonnegut used in his book, which is a really good book, you know, by the way. It's called The Heart of Caring, and it's about his, 40 plus years as a general pediatrician. And he encapsulated things that I had experienced and had seen, but had never really put that way. He called it zombie care. And zombie care could be a lot of different things. It could be care that's indifferent, care that's just bad, like just not competent care, or that it's indifferent. I think he said like not scientific, not curious. It could be dismissive. And I think we've all experienced it. Like Vonnegut brings up a really, really good point, which we talked to them about, which was that healthcare needs to be like, there needs to be a heart to it. There needs to be a genuine caring, and there needs to be like medical people, healthcare people need to be working with the patients, like according to like what their needs are and what their concerns are. Right. And I think that you're right. Like a lot of people don't talk about that. It's all about cost. And that's the result of, I think, like our political and our economic system being all about cost, because it's been made an issue of cost rather than just like a fundamental good that all of us deserve, that we should just provide for everybody, right, in a socialized way. So Vonnegut did a really, really good job of that, and contrasting, a kind of caring like rapport with the patient, as opposed to just these like rushed, like dismissive, bad, et cetera, like encounters that we're all used to getting. And it's just fundamentally different, right? Like, I don't even know that we entirely know what it looks like, because even doctors like me, our training in this system is impacted by that kind of ethic. The patient schedules, like we're dropped into that as students, and you learn, okay, this is what your schedule looks like. This is how many patients you have to see. This is how you have to fight the insurance companies. Like, we were indoctrinated into that. So I don't even know that we know what that would look like. So, but I think it's a question, you're right, that has to be thought about, because I think a lot of people just don't like the experience of healthcare. Remember, you were telling me about the experience and you were just like, man, this doctor made it clear he did not want me to be there, and he did not want to be there himself. And it's like, it's horrible. It's horrible when you feel that way, because like you're there because you have a concern, Like, it's gross when you walk away feeling like, ugh, like this person did not want to bother with me. And the feeling's mutual because they made me feel bad.
Well, and I don't know if this is true. Maybe you could confirm based on your experiences, but I always have a certain feeling of guilt There's some part of me that feels like a burden. And I know a lot of people probably feel this way. Like, when people are like, oh, do I really need to be treated for this? Is this really serious enough to where I should go to someone and have someone pay this level of attention to me? I'm sorry to waste your time. And I know that's a silly feeling. We want people to get over that, but they're going to get over it a lot less if the doctor conveys the attitude, yes, indeed, you are wasting my time and I don't want you here.
You're right. And you do hear that a lot coming from patients or from families. They're like, yeah, I know it's probably nothing, but sorry, I just came. Yeah, I know, I'm just paranoid, but, can you just check this or whatever? Like, you're right. There is a sense that patients and their like needs and concerns are burdens. You're right.
My theory is a lot of us have kind of internalized the personal responsibility stuff, where when we feel like we need to reach out for help, we also feel like we're supposed to feel bad about being dependent on someone else. So that's why there's like this little twinge of like, oh, I'm sorry, I need to be cared for right now.
Right. And the problem is that like society creates that dependency, right? Because we, like the doctor-physician relationship, I feel like gets romanticized. And it's like a paternalistic one. I mean, I think it's gotten better in modern times, but like historically, it's like very paternalistic for this doctor to just tell you how things are going to be. And you're just there listening because what do you know? You're not the doctor, right? And I think society has made it that way though, right? Because we have privileged this group of people with the information about, people's bodies, how people's bodies work, how they function, what's normal, what's not. We've privileged that within this group of people. And then we've made it such that it's very hard to access those people. When you do access it, they're busy and frustrated. And yes, so it creates that, right? But what I want to say about that is that I think that in a more ideal system where we have not just Medicare for all, but like you said, like a fully communized health system, people are not so dependent on the doctor for like all the knowledge that they need, right? Because we're going to educate people more. And something that I think about is like even like basic sex education, right? Which I've written about. We want to deprive people of that. But this is just people's bodies and how people's bodies work. And like, why is this knowledge not more democratized, right? So I do want to push back on like the doctor being just the gatekeeper here and knowing everything. But unfortunately, we've kind of made it that way. And people do trust doctors now, which is like both good and bad because like, yes, we want doctors to be trusted, but we also like need to have a society where people are educated more just on basic like bodily functions, on health, on nutrition. So you're not so dependent on like this one encounter and this one relationship for all your physiologic, like all the needs that may come up with like your body functioning or not functioning the right way,
Well, right. And then we depend on trust in the doctor persisting. And in a situation like the pandemic, where because nobody knows anything about medicine, it's all just who do you trust to tell you the truth? Because no one actually knows anything.
And that's really bad. I was looking at a website that like the Surgeon General has up about like misinformation and disinformation. And it's like he's trying to give you these pointers on how to figure out what's true and what's not. And it's like, I don't know that that's helpful. It's really hard to tell what's real and what isn't. That's a whole other issue. But
well, I wrote a while back this kind of little utopian speculative piece about hospitals, called A Healing Place, thinking about what would a hospital was actually a place to heal, to feel better when you came out of it be like, because the few times that I've ended up in hospital, it's been a horrible experience. And I've gone, why is it that this place is making me feel worse? Why is the light so harsh? Why are there no gardens? Why is this not like a place that I want to be if this is a place that is designed to heal? Again, as you say, and it's very hard to even begin to think about what the alternative looks like. But let me conclude by asking you, you talk about the importance of real, authentic justice being at the core of a reconstructed healthcare system. So as we think about what it is that people deserve, what is needed, what do you think are some of the basic preconditions of a healthcare system that would be something that we could reasonably call fair, as opposed to just have you optimize the delivery of the crumbs?
Yeah, I think it's going to be much bigger than just envisioning how you want doctor-patient interactions to go. Like some people have written about this, that like, it's not just about doctor-patient visits, people's health, right? Like going to the doctor, in a sense, doesn't like make you healthy, right? We talk about the social determinants of health, but we need a system, like a societal commitment to everybody's well-being, which means we've got to address the social determinants of health. But it also means like we've got to educate people more. And we've also got to have it more like community-based, to where we're not just having to like drive to some building to get some service. Like we need to have a much wider vision of like what's possible. Like we need community health workers, we need nurses, other healthcare people in like the communities. Like it has to be more decentralized, I think, than it is now, right? And where like people have a sense that like everybody is there to help take care of each other, I think. And so maybe part of that is we're not just talking about like medical encounters in a clinic or a hospital. We're talking about like house visits. We're talking about things in the community, so that there's a real sense that like everybody's invested in this, and like we're not leaving some people ignorant, and some people have more access to things than others. And then I think the social determinants of health part is like, that's just going to have to be like a society that looks really different, right? Where like human needs are centered, and where we decommodify the things that are commodified, that are basic human needs, right? Like utilities, food, education, healthcare, natural resources, because we just can't have basic human needs commodified because it doesn't work. Like just the way the profit motive doesn't work with healthcare, like it doesn't work for utilities, right? Like we saw that with the winter storms in 2021, right? Where just millions and millions of people without power, people even died in their homes, like in the richest country in the world, because for-profit utilities weren't there. And
yeah. And the ones who kept power got giant bills.
Yeah. So I just feel like the profit motive is the common thing here that needs to go.
They thought they were the lucky ones in Texas because he stayed on, and then they got like their entire savings accounts drained by the resulting bills. Yeah. It was so horrible that even Ted Cruz said it was unconscionable, which, my God.
He like grew a tiny little heart.
Stir his conscience takes a true injustice. Okay. Well, I can think of no better way for people to begin to think about what the real unfairness in the medical system is and how we might construct an alternative than to read Lily Sanchez's new article, We Can't Make Healthcare Fair Until We Reject the Logic of Scarcity. Also, check out Lily's previous article, We Deserve Better Than Zombie Healthcare, both printed in Current Affairs. And you can also listen to the interview that was mentioned with Dr. Mark Thornegate about his book, The Heart of Caring. Lily Sanchez, thank you so much for coming on the Current Affairs podcast.
Thanks for having me on the podcast.
The Current Affairs Podcast is a product of Current Affairs Magazine. If you are not subscribed to Current Affairs Magazine, visit currentaffairs.org/subscribe today and get our glorious print edition. The Current Affairs Podcast is released regularly every week on patreon.com/currentaffairs. Thanks for listening.